Well, once again, good afternoon, everyone. This month is coming along going through quite fast. And if you didn't realize it, man, before we know it, it's going to be the middle of April. I want to welcome you to our South Carolina Coalition for the Care for the Seriously Ill. This is our annual virtual symposium. We are thrilled to have you guys with us, and we know that there will be more people that will be checking in as we go along. This is day 2 of our symposium, and on yesterday we had heart failure and advanced directives with Michael and Crystal from Prisma Health's Advanced Heart Care Clinic with Prisma, and man, did they get us off in high gear. We will be recording, as you know, and we will also be offering the slides. Now, we will be putting the recording on our website. So for those of you who may not be familiar, we have a website called My Life, My Choices, and you can go out there and get all kinds of amazing information, not just on our coalition, but there is education for providers around, there's actually a course for providers related to post. There are resources for consumers around advanced care planning. And this month in South Carolina, this is been proclaimed by Governor McMaster Healthcare Decisions Month. And so we want to encourage you. Many of you are doing things either in your health systems, your organizations, or in community around advanced care planning, encouraging people on the benefits of putting their plans in place early before they need to have a plan. And so lots of good things happening around the state related to that. Today, I want to also welcome our partners and our sister organization from North Carolina. I see those of you that are with us today, Sangeeta and others. We've got Heather that's on, as well as some of the others that are joining us from North Carolina. Today, we are privileged to have Lea Tessitore with us. Lea is the Director of Programs at TFA Analytics, and many of you may know Tori Fields. She's doing some work in the Carolinas right now with Carinova, and so Lea works with her. In Lea's role, she manages relationships and content development with TFA's partner organizations, of which Carinova is one, including healthcare providers, health plans, nonprofits, foundations, and others. They're also doing some amazing work in states. And I just want to give a shout out for the work they have done in Hawaii and helping them be the first state in the union to have an amendment to added to their Medicaid program to provide palliative care service. A huge win for Hawaii. And because of Tori and her team, Lea and others, man, I was just on some of their information they've been sharing with their palliative care benefit that's now going to be offered through an amendment, not just a waiver. So not in danger of being cut because it is an amendment and not a waiver during these times. As a bioethicist, Lea brings a focus on the principles and frameworks of healthcare ethics to their work. She was previously an assistant director of projects and research at Catalyst for Payment Reform, which is a national nonprofit working to produce higher value healthcare on behalf of healthcare purchases. Lea got her MBA in healthcare management from Union Graduate College and her master's in bioethics from ICANN School of Medicine at Mount Sinai. And she's also certified in professional mediation through the Steinman Institute of Conflict Resolution at the ILR school at Cornell University. I'm telling you, when you're talking about working with states and payers and providers, you absolutely need to have that kind of a skill set. So Lea, we are absolutely thrilled to have you with us today. And I'm now going to turn it over to you to talk with us about this amazing palliative care project, pilot project, spearheaded by the American Heart Association and CTAC through the work of TFA Analytics. So Lea, take it away.
Thank you so much, Marisette. I'm thrilled to be here presenting to the South Carolina Coalition today. That was a wonderful introduction to this amazing work that I'm excited to present on. And so today's topic will be the pilot, improving quality of life for people with heart failure through integration of palliative care services. I'm just gonna, okay. All right, are my slides advancing?
Yes, we can see your slides. I had to get myself unmuted, but we can see your slides really well. Thank you.
Excellent. Sorry, I had to minimize the little toolbar so I can't
Yeah,
totally see.
we'll have time for questions at the end, everyone. So feel free to jot your questions down. I know yesterday I had lots of questions, but we want to definitely there'll be some time at the end that you can talk with Lea. All right.
Perfect. All right, so also known as in short as the Palliative Care in Heart Failure Pilot, the goals of this project when we started were to first recommend eligibility criteria for heart failure patients' referral to palliative care services. The second main goal was to develop a standardized palliative care referral pathway for eligible heart failure patients. Produce messaging materials for enrollment, including outreach materials to consumers and providers participating in the pilot, as well as in the broader communities of the states in which we implemented the project. And then ultimately, we were hoping to contribute to building the body of evidence for the benefits of integrating palliative care services into cardiology care for people with heart failure, such that a standardized eligibility criteria and referral pathway that came out of this project could be replicated at other sites across other states and continue to show the value of palliative care in heart failure. And so specifically looping back to the first two goals here, the eligibility criteria and the referral pathway, we wanted to understand, who would be the best candidates or the most eligible to receive palliative care services when we're talking about heart failure patients. And then when we say referral pathway, what we're talking about is once we sort of pin down the eligibility criteria for who would qualify for the pilot program, what would trigger their referral to the services and what would that workflow look like operationally to get them access once they were identified? And so sort of those two pieces together were the heart of the project along with the other materials and of course building a body of evidence. This project started in January of 2023 and ran through November with an extended period for data collection. And there were three main phases in the project. So first, there was the site selection, so picking members for the advisory council and bringing them together. Also trying to select which four states we wanted to implement the pilot in, and identifying health plans, health systems, and coalitions focused on serious illness care or palliative care in each of those states to sort of work as a group within each of our sites. Phase two of the project was creating and coming to consensus on the eligibility criteria and referral pathway, and also the evaluation methodology for the project. And I apologize, it looks like there's a little bit of a formatting issue, but phase three was also focused on implementation and evaluation of the pilot. Phase three is actually something that both AHA and CTAC are seeking additional funding to support still. So happy to connect with anyone interested, but that would really be to focus on, now that the eligibility criteria and referral pathway have been created and the different plans, systems, coalitions at each of our four sites have gone through an implementation planning process and planned out what their pilot would look like and are sort of underway implementing that. We wanted to add an evaluation component, and that would be phase three. To really focus on fidelity and adherence to the model. Is the criteria working the way it was intended? Is the referral workflow giving access to palliative care for those with heart failure? And what are the outcomes that are coming out of that pilot? And so those were the three main parts of the project. And as I mentioned before, this happened over the course of 2023. Okay, there we go. So, digging into the specific palliative care and heart failure sites, the advisory council, and the project team. The project team consisted of folks from the Coalition to Transform Advanced Care, CTAC, from TFA Analytics, as well as external expert consultants. So we had Dr. Brian Castle from Virginia Commonwealth University, Tori Fields from TFA, Marion Grant, a senior advisor to the Coalition to Transform Advanced Care, Jennifer Driscoll, also from CTAC, Steve Dentel from the American Heart Association, Kristen Engelhardt from AHA, and Melanie Phelps from AHA as well. So we had folks from each of these three organizations comprising the project team. And the role here was really just to oversee the project and the various work streams underneath. So guiding the advisory council, doing literature reviews, reviewing, making sure the sites were engaged in implementation planning, and everyone was providing feedback. So it was a great collaboration between all three organizations. And we were very thankful to be able to have such a great project team guiding this project. These were the folks on the National Clinical Advisory Council. We had Dr. Larry Allen, Dr. Gwen Bernacki, Caroline Doherty, Dr. Laura Gelfman, Dr. Nathan Goldstein, Dr. Michelle Kittleson, Dr. Aguini, and we had one observer, Dr. Parekh. I won't go into all their credentials, but essentially what we were looking for when we were comprising the Clinical Advisory Council was we were really going for folks that were national experts and leaders in their field in the area of palliative care or in cardiology and/or cardiology. They didn't have to be located in the specific states that we implemented the pilots in, but we were looking for that sort of national level view and expertise in palliative care and cardiology, such that they would be able to guide the formation of the eligibility criteria and the referral pathway, and also give advice to the sites as they began their implementation planning process. So speaking of the site participants, we wanted a minimum of 4 health plans, 4 health systems, and actually 4 coalitions across 4 distinct geographies or states. In order to find the site participants, we were looking for health systems that were delivering a high volume of cardiac care in their region already. We wanted to make sure that the health system also had some type of identification tool or mechanism in place for palliative care eligibility and referral pathways already. And this would just help to ensure that they had a good foundation for participating in the project. We also wanted at least 2 regions with health plans that were covering palliative care services already through value-based payment. It's not listed here, but we also wanted to ensure that each of the 4 states or geographies that we selected were also diverse in geography and culture and politics. And that was just to help ensure that when the project was completed, we could say that the eligibility criteria and referral pathway was able to work in a lot of different systems in different environments. And that would just help speak to the universality of the project's applicability, and as well as the criteria and referral pathway as well. So the coalition partners that sort of acted as the partner to the health plan and the health system within each state, they acted as the local consumer voice and subject matter expert in the community, as coalitions are the ones that are on the ground and really have their finger to the pulse of local issues in healthcare. It was really important for us to bring them on as a partner and as that community expert. We also partnered with the coalitions to provide input and guidance on the consumer and provider collateral produced as part of the project, to administer training to the community and providers on palliative care services and use of the referral forms. The translation of materials into languages was something that the coalitions also took the lead on. And they also partnered with us in the dissemination and adoption of tools and outputs after the project concluded. So these were the site participants that ultimately participated in the project. We had 4 states: California, Hawaii, Louisiana, and Alabama. And so in California, our triad, if you will, was the Cedars-Sinai Health System. We had 2 plans in the state, so Blue Shield of California and Health Net, who were the payers that participated, and our state coalition was the California Coalition for Compassionate Care. In Hawaii, we partnered with Hawaii Pacific Health as the health system, Blue Cross Blue Shield Hawaii, or HMSA, in as the health plan, and then Kokua Mau was our state coalition partner. In Louisiana, we worked with Ochsner Health System, AmeriHealth, Caritas, and Humana were the 2 payers that participated, and the Louisiana Healthcare Quality Forum was our state coalition partner. And lastly, in Alabama, we partnered with the University of Alabama, Birmingham, Blue Cross Blue Shield Alabama as the health plan partner, and the Alabama Council on Palliative Care and Quality of Life as the state coalition. So we are very pleased with the site participants that we were able to recruit from the project. And it was great to be able to work with each of those in these 4 different states. So after the advisory council and the site participants are selected, we then moved on to, through phase 1 and phase 2, which is creating the referral criteria and eligibility pathway for the project. When trying to decide on the referral pathway and what design principles we were looking at sort of as an overarching view when going into this process, we wanted to make sure that we were taking into account evidence-based standards that already exist for when to refer patients with cardiac issues or heart failure to palliative care services. We wanted to also make sure that whatever criteria and referral pathway we ultimately came up with was feasible and able to be implemented across the healthcare payers and the health systems that were going to be using it. And so this was where in the site implementation planning meetings with the health plans and the health systems, they were also able to provide feedback on the criteria and referral pathway as well as the advisory council. We also wanted to ensure, as I mentioned before, that this referral pathway was able to be replicated across various geographies and settings, and also built into a process flow that includes a standardized referral process. So in general, I think we just wanted to make sure that it was evidence-based, it was feasible, and that it's able to be replicated and usable for the health systems and plans participating in the project. So to achieve consensus on the referral pathway, the project started with a literature review. So this speaks to the existing evidence on when to refer patients with heart failure to palliative care services. So Brian Castle at Virginia Commonwealth led this work. And so it was a review of palliative care and heart failure clinical trial criteria. International heart failure clinical guidelines were also looked at to understand what is the existing evidence out there for that referral to happen. And that would then inform our own eligibility criteria and pathway. We also took into account the direct input review and then gaining consensus within the sites and the advisory council on our criteria and pathway. We also socialized it during the pilot implementation meetings so that as the different sites were going through planning out their pilots, they could see how the criteria was evolving and provide their input and take that into account during the pilots as they would be, implementing that specific criteria and pathway. And then we also used a variety of survey mechanisms to collect feedback from the sites and the advisory council as well. So those surveys were distributed outside of the regular meetings between the advisory council and the sites. And then, of course, as we ingested all of this feedback, we went through a process of revisions and then going back to our different partners to gain consensus on what would ultimately be the referral pathway and final eligibility criteria. So this is what ultimately came out of the project. This is the eligibility criteria and referral pathway. There was 2 parts. There was a disease-based criteria. So Um, all patients with stage D, that includes heart failure symptoms that interfere with daily life functions or lead to repeated hospitalizations. Or it could be class 4, so heart failure symptoms at rest, any physical activity that causes further discomfort. These would meet the disease-based criteria for referral to palliative care services for those with heart failure. Just digging into the disease-based criteria more, patients with stage C or class 3, which would be marked limitation of physical activity, they're comfortable at rest, or less than ordinary activity would cause fatigue, palpitation, shortness of breath, or chest pain. They may meet the criteria, especially when any of the additional following conditions are present. So major complications of heart failure, such as cardiorenal syndrome, additional cardiac conditions, such as advanced cardiac amyloidosis, and I apologize if I mispronounced that. If they are considering a transplant, an LVAD, or other types of similar conditions or treatments. If they show multi-morbidity, such as advanced cancer, liver disease, renal failure, if they have frailty or declining function, or 2+ hospitalizations for heart failure decompensation in the past year, clinical estimated life expectancy of a year or less, or persistent LVEF of less than or equal to 40%. These criteria aren't listed in any particular order, but this sort of complements the previous slide in that they could meet the eligibility criteria based on being stage D or class 4 or stage 3 or class 3 if they have any of the other following conditions or symptoms present. The other part of the referral pathway was consideration of specialty palliative care needs. As heart failure guidelines indicate, primary palliative care should be delivered to all heart failure patients by the cardiology team, primary care team, etc. But specialty palliative care may be needed when any of the following conditions occur. And so persistent symptoms, despite optimal medical therapy, if they need assistance with goals of care discussions, such as advanced care planning, if there is moderate or severe physical, emotional, or spiritual distress, if the patient needs assistance with major medical decisions, assistance needed to understand and make decisions about palliative care, if patients or families are requesting palliative care services, or if there are other indications that specialty palliative care could be beneficial to the patient according to the provider, the referring provider. And again, these aren't listed in any particular or ascending order. So that was the eligibility criteria and referral pathway that was then going to be pilot tested at the 4 sites. The sites were encouraged to use these criteria and this pathway in their pilot projects. And like I said, as they went through the implementation planning, those criteria were not only run by them, but taken directly into account as they planned out their pilots so that they could actually test the pathway in action. In the next phase of the project, should it happen, the evaluation would also take a look at clinician perspectives on how well the pathway is working and how they feel the outcomes are going for them and their patients. So the last part of the project, which we are hoping to get underway, is the evaluation phase, as I mentioned before. And so this would be the evaluation of the pathway to deliver specialty palliative care consultations to eligible patients with heart failure. And this would be across the 4 participating health systems. We'll be looking to collect supplemental claims data from the participating health plans in order to develop a prospective cohort of patients to evaluate and determine the impact of the referral pathway on various types of measures, including quality of care, utilization, cost, provider and patient experience, etc. The goals of phase 3 would be to finalize an evaluation protocol that takes into account experience of care and total cost of care for people with heart failure. We also want to monitor and evaluate the referral pathway across all 4 sites and ensure fidelity to the model. And lastly, disseminate any results with health system leadership, healthcare payers, and interested policymakers so that we can contribute to the evidence base, show that this criteria can be universally applicable, and contribute to the value, understanding the value of palliative care for people with heart failure. Like I said, we're currently seeking funding to start phase 3 of the project, and we also would invite any other sites around the country that are interested in this pilot or curious to learn more to feel free to reach out to us to learn more about the program, as we would love to continue to expand and scale this model. And with that, I think that that wraps it up. Hopefully, I've left enough time for questions. I'm really excited to answer any questions you have. And again, thank you for inviting me to present today.
Awesome, awesome. Thank you, Leah, for that wonderful overview of this pilot. And of course, there are definitely a few questions that come to mind. We're going to make sure we can put the gallery up so we can see hands of individuals that may want to ask some questions. I will definitely kick us off as we begin to sort of look at these pieces. I don't know, Jessica, if you can put everybody up, that would be great so we could see I can't see their hands now, but you guys can definitely unmute yourselves or put your questions in the chat. So, one of the things that I'm curious about, the American Heart Association, one was the impetus for them to sort of look at doing a pilot of this nature. Were they getting calls from physicians that are connected with them around the need for palliative care? But how did this come up?
Yes, so this was part of the Implement HF initiative, which is an initiative under the AHA. So, as part of this initiative, they had a project improving quality of life for people with heart failure through the integration of palliative care services. And so that was this project. And so our project was sort of under the umbrella of Implement HF. And really, the overall vision for Implement HF was to create a healthcare ecosystem for heart failure that emphasizes implementation science and patient engagement. And so that really spoke to this project in particular because this was an implementation project. We were directly working with 4 sites to develop an eligibility criteria and referral pathway, and then pilot that actual criteria at each of the sites and then measure and evaluate the results. And so patient engagement, obviously a part of that. There were, real patients who participated in this project and are referred to services based on the pilot. And so it really just fit well under that Implement HF vision. And so that was really sort of the background or the context for working with AHA on this project.
Oh, very good. On yesterday, we kicked off with two of our folks from Prisma really talking about heart disease and the fact that heart disease is now the number one killer, cancer is number two. And so the great need. And I saw that one of the things that you developed was the messaging piece. Could you share a little bit more about the messaging as it relates to patients and their willingness to take on this? Why this was one of those pieces that needed to be looked at as well.
Yeah, absolutely. And so Marion Grant led this work for the project. She's an expert in patient communication and communication about palliative care in general. And so the reason, I guess the overall reason why messaging was so critical to this work is because there is still a lot of misunderstanding about what palliative care is among the general public and consumers. I think we all remember the death panel comments from many years ago that have still managed to not leave us. And so it's just really important to understand, especially when someone is dealing with a serious illness, like heart failure, that when we're implementing a pilot for palliative care, that it's not misinterpreted or misconstrued as hospice. we really want to make sure that they understand that palliative care is something that can be added onto their care as an additional layer of specialty support that can help patients, do better while they're also receiving curative treatment. And so, in general, that is why the messaging is so important to projects like these. Specifically, some of the overall messages that were developed as part of this project were to make sure that when we're communicating about the pilot, we're making sure to talk up the benefits. So making sure we not only explain what palliative care services are outside of the context of hospice as a standalone service, but to make sure that we're also emphasizing that these services improve care and improve people's quality of life. We also want to integrate messages like palliative care helps present choices at every step, at every stage of an illness, every treatment decision. Patients have choices that they're able to voice and able to make when engaging in palliative care. Other key messaging principles that came out of this project were to make sure that we're using stories to sort of emphasize and reinforce the benefits of palliative care. We want to make sure that stories are positive, they resonate with patients, they're aspirational in nature, and we want to ensure that providers and patients are talking with each other as opposed to talking at someone or just talking once with them about palliative care. You want to make sure that there's a call to action, that there's ongoing conversations. And then also emphasizing that palliative care brings a new team into the picture. So patients, families, clinicians, and even the community all really have a role in palliative care. And so with those sort of messaging principles in mind and sort of the overall importance of educating, even providers as well as consumers on the importance of palliative care, those are sort of the messaging components that came out of the project and why they were so critical.
Mm. That is so good. You know, one of the things I love is to hear the testimonials because that's something that resonates with consumers. Someone's story about how they got better because they utilized the service, and obviously we want people to get palliative care sooner than later, further upstream than towards the end. And where there's any discussion around the fact that they started at, stage D or class 4, and then stage 3 could be in there, but no sense of kind of someone was at stage 2. Was there any sort of among the clinicians? It sounds like they all landed on stage 4 or D or stage 3, or C. Was there any thoughts about, stage 2 or a little bit sooner, that as soon as somebody is diagnosed with heart failure, that maybe we should get palliative care going earlier? Any discussions at all that came up around that with the clinical advisory team?
Yeah, that's a great question, Marisette. And unfortunately, that's not something that I can speak to. I was not around when that part of the project was implemented. So, but I'm more than happy to take that back to Tori and the team and loop back with the folks on the coalition to the answer to that question.
Okay.
What I will say though is I do want to emphasize something that you brought up just now and that you mentioned at the beginning of the event, which is that palliative care is appropriate at any time and at any stage of a serious illness.
Mhm.
And so even though this criteria, as you noted, did focus on the latter stages of heart failure, as soon as someone is diagnosed with a serious illness, it is appropriate to have a conversation about palliative care and how that care can be integrated into their care journey moving forward and how it can benefit them. Because it is important to note that it's delivered alongside curative treatment and
Mhm.
can be extremely beneficial, not just in quality of life, but actually improving clinical outcomes for people as well. And so that's really important to emphasize. I'll also say that you mentioned the Hawaii spa at the beginning of the event as well, and it was a landmark for sure for palliative care and for Medicaid benefits. But it also classified palliative care as a preventive service.
Yeah.
And so that was really something to note because I think it really helps speak to the benefits of palliative care, what it really is, and that it's helping to shift that mindset of palliative care as not being hospice care. It's shifting it out of the end of life realm and further upstream, really, where it belongs.
Mhm.
And so I think that's something that also resonates in the messaging, which you were just talking about as well. I did mention patient stories, and to your point, Marisette, we want to make sure that patient stories that we're showing to promote the benefits of palliative care are not like good death stories, so to speak.
Yeah.
Um, we want to make sure that the stories are showing that people are living well with palliative care. So.
Mhm. That is so good. I know on yesterday, this story, I don't know why it stuck with me, but a gentleman that was treated by receiving supportive care with the advanced clinic with Prisma could not clean out his refrigerator. And so, with, just looking at the medications they did, the total team support, and all the treatment interventions, he was able to have an improvement in his quality of life, to be able to walk further, to have energy when he got home from work. And I think those are the things that, that sort of they combat that message that palliative care is just about dying, that palliative care is about the support that you can live without symptom burden, and have the quality of life, that you want, and get some more time, to be able to spend with family and friends. So, well, I'm going to hush because there's probably other people that have questions as well. I don't see any in the chat, but if there is anyone, feel free to unmute yourself and ask any questions that you may have of Lea. I felt like we were doing an interview just there, right there, Lea. We didn't talk about these questions ahead of time, but as I was hearing you share, they came to mind for me. Are there any additional questions from anyone? All right, I cannot see any messages in the chat. And so, very good. I'm not opposed to giving people time back into their day, if that's where we land. But want to make everyone available. Want you to all know that, of course, that the slides will be available to you, and the recording of our session today will land on our website in just a couple of weeks after we get a chance to kind of go through them. We'll post them on our website. I do want to ask each of you to take a moment before I'm going to put it in the chat, to evaluate. We're evaluating each of our sessions, and any additional information that you would like to receive, or other topics as we continue to work on our educational programming for the rest of the year for the coalition. Lea, we certainly appreciate you taking time out of your day. You're one of our national folks, and I know that you guys stay busy traveling across the country, helping folks get this work done. And particularly as we look at palliative care, there are some other states that are looking at doing amendments as well, and making palliative care preventive service. That is the operative word. And so we are grateful for the work that you guys are doing, that's paving the way for other states to consider this as well. So definitely thank you again for being with us today. I want to encourage everyone, as it is South Carolina Healthcare Decisions Month, we want you to be out and about. I'm busy doing some things with churches and the aging community, as well as going to be at Prisma doing a few talks on advanced care plans. So Crystal, I might see you at some of those events that are coming up this month. So guys, get the word out. More than anything, we want people to have conversations, right? We want them to begin talking to their families, not waiting until there's a medical crisis when the pressure's on and they're starting to have these conversations. I had a pastor tell me the other day that he had a woman at the age of 96 who came to him because she did not have family. Her husband had died several years before, and she asked him to be her healthcare power of attorney. She told him everything that she wanted, her funeral plans, where she was going to be buried. And she lived, guys, until 101. And she even told him that once the funeral was paid, she had some cousins in New York. If there was any money left over, and if they came to her funeral, to give them the envelopes with the extra money. Now that is someone, even at 92, you're thinking, oh, but she wanted to get her affairs in order. And so at any age from 18 on up to 101 and beyond, because we do have some seniors that are living for a while now, we want to make sure that people are having these conversations. It saddens me to know that there may be people who have no family, but I saw where you mentioned the spiritual care aspects, and for some people, their pastor or their or their priest may be that person who steps in to help them. There looks like there may be a question here while I was telling you guys about this. Um, so this question may be repetitive. It's probably not. Lea, can you share who Hawaii was able to get the palliative care amendment passed for Medicaid, how that was done? Oh, yeah. Lea can tell you about that.
Yes, absolutely. I'm happy to share. So it was about a year-long process, taking into account that, when something goes to government, it can take, a little while to get through. But essentially the process that we used to get the SPA or the state plan amendment over the line was to sort of work with the community to understand what palliative care needs were, what the capacity of the state was to deliver the services, and where they were able to. And so first it was an understanding of which palliative care providers were in the state, what types of services they were delivering, and what their service area was to understand the capacity. What's important for a state plan amendment is to understand statewide-ness. So in order to add something, as a benefit to Medicaid or to the budget in this case, we wanted to ensure that the state had the capacity to deliver these services statewide. And so that sort of state capacity assessment of who are the palliative care providers and where are they was really critical to understanding first. We also needed to understand how many people within the population might be eligible to receive the services. And so that was the demand component as well. So that was another sort of piece of a quantitative analysis that was done to understand the environment of the state. There was the drafting of the actual SPA language, and that would include, what services would be covered under the state plan amendment, what would the reimbursement model look like, who would comprise the interdisciplinary team, and what qualifications, credentials, would they need to have in order to qualify as members of that team. And so there were some operational aspects as well. And so drafting out the actual SPA. And then there was a process of community stakeholder feedback where we needed to understand, there are, as we mentioned, local needs and different issues that arise in each state that are tailored to the community. And so the stakeholder feedback process is really meant to socialize the benefit throughout the state and also obtain feedback from the people that are going to be directly impacted by it and implementing it. So consumers, providers, policymakers, health plans, we wanted all of their input. And so there was a long sort of process to collect the stakeholder feedback, which was then synthesized, analyzed, and incorporated into the draft SPA language. And then from there, the SPA language was finalized and submitted to CMS, and it was approved. So that was sort of a high level run through, but it is a process that we use to sort of, understand whether or not a SPA can be implemented in the state. I think, Maris, that you mentioned this at the very beginning of the webinar, but we do prefer the SPA route is probably preferable because a waiver is something that is a pilot and that will actually end after a defined period of time. And without further funding, it may not continue. Whereas a SPA, which is an actual addition to the budget of the state, that is something that will endure. And so it's something that is preferable. But in order to implement a SPA, there are certain qualifications that need to be met. So I mentioned, is there statewideness? Have we taken into account feedback from the community, and how does that impact, the services, the team composition, the reimbursement model, et cetera? But that's sort of the overall process that we would take in order to work with the state in order to implement or submit a SPA to CMS for approval.
I think right now New Jersey is working towards their SPA amendment, their SPA plan. Am I correct in that?
Yes.
And they've been very engaged in doing surveys and state engagement. This also plan also with preventative. Also, what I learned from the Hawaii public webinars they did just recently. They did a four-part series, and part of that also pediatrics. Very much involved as well, and really looking at all of the disciplines that need to be involved in this preventive piece. So, child life specialists, social workers, um, of course, you've got clinicians, but really looking at the therapy services, spiritual care. So, when they put all of this together and looking at all the pieces, I was amazed at all of the things they included to make sure that nothing was missed when they put together the amended, totally looking at the total person and how those things interact. So yeah, Hawaii is very proud of this amendment, as they should be. And every one of the sessions that I listened to, they are just ecstatic. And the plan, of course, the Medicaid plan, they're working with it as well. So very good, very excited for them as well. So, other questions? All right. Well, we want to thank all of you again for jumping on with us today. We're going to give you a little bit of time back into your day. Remember, on tomorrow is our third and final day of our virtual symposium. And tomorrow we are going to be diving into the work with Caranova, with Dean Higgins and team, as they talk to us about the palliative care outpatient care model project and what they are doing with that as well. And so on tomorrow at 12 o'clock, we'll hear from Dean Higgins and Christina and also one of their other colleagues from Blue Cross from the payer side to talk about the outpatient palliative care project that's being done at MUSC. So you don't want to miss out on that and to see what we're doing, of course, here in the state. So have a wonderful afternoon. Make sure, hope you guys have already clicked the link for the evaluation. I'll put it back into the chat. I'll keep it open for a little bit. Lea, you're getting all kinds of love in the chat from the folks, thanking you for this wonderful information today. There's some folks thinking about what can we do here in South Carolina? What can we do to make things different? And to increase access to people for the services, particularly with Medicaid. So once again, everyone, have a wonderful afternoon, and we look forward to seeing you again on tomorrow. Bye-bye.